I would like to welcome Amged Soliman, the Senior Attorney Advisor for the National Council on Disability. The National Council on Disability's mission is to be a trusted advisor in collaboration with people with disabilities to the President, the Congress, federal entities, state, tribal communities, and local governments, and other entities and organizations. Lately, I have to say they've been on fire. They've been presenting a wide range of analysis and recommendations of interest to healthcare providers, and we are delighted to have Mr. Soliman here today to tell you more about the work of the National Council on Disability and their powerful portfolio of work. Welcome.
Hello, everyone. It's a pleasure for me to join you today. I'm happy to be here, and I'm happy to go over some updates by the National Council on Disability. I believe I've already been introduced, so I think we could just jump in. Next slide, please. I have nothing to disclose with respect to this conference. Next slide, please. Okay, for today's discussion, we're going to review the NCD framework to end health disparities of people with disabilities, the main recommendations found within it, the current status of those recommendations, as well as a review of other recent NCD health-related reports. Let me just state quickly, I'm not sure, I wasn't able to hear the introduction, but for those of you that are not familiar with the National Council on Disability, we're an independent federal agency. We advise the President and Congress and other federal agencies on matters of disability policy and law. We've been around for several decades. I think probably the most famous law that we ever recommended and helped draft the first version of was the American with Disabilities Act itself, to just give you an idea of the type of things we do here at NCD. But as you all know, there's always more work to do, including within the health disparities field. So that is what I'm focusing on today, obviously, and I'm excited to get to the rest of it. Next slide, please. Okay, so I'm going to go over some other reports and recommendations that NCD has made in this space, but I'm starting with our framework. We decided a few years ago to put together a holistic set of recommendations that we feel are pertinent with respect to helping to end the health disparities of people with disabilities, of which there is a plethora of research and data to indicate that there are indeed significant disparities between people with disabilities and our friends. So although the framework has maybe 39 or so extra recommendations, it does have 5 core components, as I alluded to earlier. And those are that there should be a designation of especially medically underserved population with respect to people with disabilities. We recommended that people with disabilities should be designated as a health disparities population, which is different from that first core component I just alluded to. That there should be comprehensive disability clinical care curricula, that basically healthcare providers should be trained in disability clinical care and competency. Accessible medical and diagnostic equipment was another core recommendation, and improved data capturing. And I'm going to go through each of these. Next slide, please. And I know we're limited to about 30 minutes plus question and answer, so I'm trying my best not to waste any time as I go through these, but hopefully I won't be going too fast for anybody. So with respect to the first core component, designated people with disabilities as a special medically underserved population. And the reason the term special is used is only because that's the legal term used in the law. Congress can do something, would have to be the one to act to do this. But I should give you a little bit of background here. So anytime you have a population that suffers health disparities, they can be designated as a medically underserved population administratively. And this is something that's typically done based on geographic locations. And the Health Resources the Health Resources and Services Administration can designate people with disabilities as a medically underserved population under the Public Health Service Act. Now, typically, these are done based on geographic areas and population groupings in specific locations. But that's not obviously something you can do with people with disabilities because people with disabilities are across the country. So how do you go about addressing that? Next slide, please. Actually, previous slide, please. Sorry about that. So if you can't make the designation based on specific geographic areas because people with disabilities are across the country, what do you do about that? Well, it's the same problem that they had with the homeless population and residents of public housing and migrant farm workers. And the way that was dealt with in the past was that Congress designated those groups as what's called the special medically underserved population. It requires Congress to revise the Public Health Service Act to make a special designation for the group so that the members of that group throughout the country can get this designation. And of course, bringing people with disabilities into the community, the Olmstead decision, those were all wonderful things. And because people with disabilities live across the country in not specific geographic locations, the same designation would have to happen for people with disabilities through that special medically underserved population designation that require Congress to revise the Public Health Service Act. And that was NCD's recommendation. If that designation was to occur, it would open up, based on how Congress sets it up, a plethora of benefits to people with disabilities, including access to federally qualified health centers, improved training potentially of people that serve in those FQHCs, and other means of helping to end the health disparities of people with disabilities. So that was core recommendation number one. A lot of people feel that it's the sort of the solution that helps with so many other necessary solutions, but obviously it's a challenging thing to get done. Next slide, please. Core component number two. This is the health disparities population designation. And as I said before, this is different. Health disparity population designation is something that would happen administratively under the Minority Health and Health Disparities Research and Education Act of 2000. It exists if there's a significant disparity in the overall rate of disease incidence, prevalence, morbidity, mortality, or survival rates in the population compared to the health status of the general population. I am pleased to report, for those that are not already in the know, that we can check this one off the list. This happened already. We made this recommendation in the framework, and it wasn't too long ago that people with disabilities were designated as a health disparities population. And what that does is it opens up a lot of research opportunities through the NIH that would help produce necessary research in the field of the health needs of people with disabilities. Next slide, please. Core component number three is comprehensive disability clinical care curricula. Most health providers report that they've had little to no training and exposure concerning disability clinical care and competency. Things have developed in this space of late on the oral health side. A few years back, obviously the same program was happening on the oral health side. Dentists and other oral health providers weren't largely trained to treat people with disabilities, including people with intellectual and developmental disabilities. And at the time, the American Dental Association's Code of Professional Conduct did not state that a provider is not permitted to turn away a patient based on their disability, believe it or not. It said that you cannot turn away a patient based on their race, gender, other protected groups, but it did not say you cannot turn away a patient based on their disability. So we recommended it to the American Dental Association that they revise that, and they did. The ADA code now says that you cannot turn away a patient based on their disability, and if you're not capable of providing the necessary treatment, you must refer that patient to a provider that can provide treatment. And then we recommended to the Commission on Dental Accreditation. They're in charge for the standards of oral health professional schools across the country. They're responsible for the standards set for those schools. We recommended to them that they revise their standards and make it so that oral health schools, including dental schools across the country, are required to train their students to manage the treatment of patients with disabilities, including patients with intellectual and developmental disabilities. Initially, the standard was going to be revised to state that dental schools across the country have to train their students to manage the treatment of patients with IDD. That actually opened up beyond patients with IDD to other people with disabilities, which we were pleased about. So we could check those boxes to those extents on the dental side, but the medical side has proven to be a little bit more tricky. Obviously, on the medical side, there might be a tendency to look at this through a medical lens, and what I mean by that is not necessarily view people with disabilities as a demographic population that requires certain needs. So our core component number 3 is that healthcare providers have to be trained in disability clinical care and competency. There are some medical schools in the country that include that in their curricula. Harvard is a good example. Other schools are a good example. But the overwhelming majority of medical schools do not include this in their curricula. And the overwhelming majority of residency programs do not train their residencies in this space, their residents rather, in this space. And it's our recommendation that something has to be done about this. I think of late, there are certain awakenings among residency program heads that this is something that has to be tended to. The ACGME, which stands for those of you that don't know, the Accreditation Council of Graduate Medical Education, and the AMA, they just conducted a joint conference in Chicago a matter of days ago, where they were talking about this very issue. And we'll see if we can move the dial further on this issue. Next slide, please. Core component number 4, accessible medical and diagnostic equipment. This was a core component, and after the release of our framework, we were happy to see that the HH Office of Civil Rights, Section 504 of the Rehabilitation Act of 1973, something was done about this. There was a rule, and we're hoping it'll help make a difference in a positive direction. Next slide, please. I hope I'm not going too fast for everybody. I know that we're on a time clock here, and also it's a little bit challenging to be presenting without being able to see anybody. But please interrupt me if necessary. But I'll be sure to leave time for question and answers at the end. Core component number 5, improved data collection. So obviously, the more data you have to work off of, the better it is to help address the health disparities of people with disabilities. So our core component number 5 was to deal with data collection. We believe that the needs of people with disabilities need to be taken into consideration with respect to public health surveillance systems, but also with respect to electronic health records. The needs of people with disabilities have to be noted basically from the point of their admittance into a hospital or other health provider venue until their release. We have gleaned from the data and from our discussions that when electronic health records are inclusive of the needs of people with disabilities, it is of utmost importance to the patient. Next slide, please. So those were our core 5, and as I mentioned, we're happy that we have seen the dial move forward on several of them, and we continue to make our recommendations with the work that remains to be done. NCD has put out other reports in the space of health disparities in the past few years. Just wanted to draw your attention to some of them. We put out a report, Medicaid Oral Health Coverage for Adults with Intellectual and Developmental Disabilities, a Fiscal Analysis. And what we decided to do there is take a look at the data, for all the 50 states. Which states provide oral health coverage for people with IDD through Medicaid? Which states provide very good coverage? Which states provide okay coverage? And which states do not provide really any coverage at all outside of perhaps ER coverage? And what we found was that of the 12 states that really didn't provide any coverage, except for perhaps emergency room coverage, we found that when crunching the numbers, that those states would actually save more money in providing this Medicaid coverage than they're spending at emergency rooms when people who do not have access to preventative care have to come to the emergency room when their oral health gets out of hand, and you actually would be in the black by doing these programs because of the money you save. So that's win-win, right? It saves costs for the states, and you're also doing the right thing by people with IDD, giving them the healthcare access that they need. So of the 12 states, I think actually 11, the numbers we crunched showed that they would be in the black by doing this. The 12th state was the state of Nevada. It showed that they would virtually break even, which in it of itself would be an amazing thing. I mean, if you can provide this kind of coverage and it be cost neutral, I think the difference of maybe $60,000 cost to the state, which $60,000 to a state's budget is dust. It's nothing. State of Nevada, so it would virtually break even. So of those 12 states, actually, it was the state of Nevada that took this recommendation and did implement such a program. And it's currently in the process of implementing an oral health Medicaid program for people with IDD. We were very pleased to see that, and we're going to continue to see if the other remaining states that could really benefit from this recommendation are going to take this recommendation. Next slide, please. We did another report, the implicit and explicit exclusion of people with disabilities in clinical trials. In it, we recommended that the FDA and HHS should develop guidance on eligibility parameters for investigators, similar to FDA's informed consent guidance for institutional review boards, clinical investigators, and sponsors. And that clinical trial study teams should incorporate overt explanations and justifications of the availability of reasonable accommodation in informed consent documents. It wasn't too long ago that this report was released, but we continue to monitor and see what effect, if any, of our recommendations has had or will have. Next slide, please. Another NCD report we put out not too long ago, it was called From Fetal Surgery to Gene Editing, the current and potential impact of prenatal interventions on people with disabilities. And what that does is it explores the potential for disparate harm from some technologies and the need for appropriate access to others, and offers findings and recommendations for the administration, Congress, and states to ensure any prenatal interventions do not disproportionately harm people with disabilities. We advise anybody who is listening to this lecture to please get on our website, ncd.gov. All of our reports are published there. Take a look at our reports, read them, and hopefully you'll find that they are useful. Next slide, please. So I mentioned earlier that NCD had recommended to the American Dental Association that they revise their Principle of Ethics and Code of Professional Responsibility to state that a patient cannot be turned away based on their disability. And then that also resulted in the Commission on Dental Accreditation doing the right thing and revising their standards to state that all dental schools in the US have to train their students to manage the treatment of patients with IDD and other patients with disabilities. So I'm mentioning this again because there has been some successes in this space. Obviously, there's a lot more to be done, but sometimes it's helpful to see some good news, to see the benefits of some of these recommendations being implemented. Obviously, before these recommendations were accepted, and even to a great extent, even now with these recommendations being implemented, there's just too many people that had to travel too far just to find an oral health provider willing to treat a patient with IDD. I mean, you hear horrible stories of patients have to travel to other states just to find somebody who can treat them. And you hear other stories of, patients who have to wait months and months just to find a dentist that can treat them. Parents waiting months and months and months to find a dentist that can treat their child. But the New York Times, after some of these recommendations were accepted and were implemented, the New York Times did a story about a little girl named Bella. It was called "Saving the Teeth of Patients with Special Needs." That link is right there if anybody would like to follow that link to the New York Times article. And it tells the story of a mother who just could not find a dentist who was willing to treat her daughter, or could treat her daughter. Her daughter has IDD and has an intellectual developmental disability, I should say. And she finally found one that was willing to treat her daughter, but she was told that the appointment was going to be months away. She patiently waited those months and months, and then the night before, and they were very excited that they would finally at least get somebody to treat their daughter. And after waiting several months, the night before the appointment, the mom was called and told that the appointment was being canceled. And as you can imagine, she burst out into tears, understandably. And so the person on the other end of the phone said, "Okay, hold on. Let me go look up what the Code of Professional Responsibility from the ADA says." And she found that the code now states that you cannot turn away a patient based on their disability. And if you're not able to treat the patient, you must refer the patient to someone who can. So Bella was referred to a wonderful facility at NYU. Next slide, please. And as you can see in this photo by the New York Times, Bella had a happy ending that day. She was able to see providers that were able to treat her at NYU. And she, of course, was very pleased, and her parents were very pleased. So sometimes there are happy endings, a lot more work to do. But I think this helps show that when good recommendations are adhered to, it can make a real difference. Are there any questions?
Yes, and we do have some questions for you. One question is, how is this different, I think NCD's effort, different than the Heads Up Act, which will designate disabled people as a special medically underserved population? That act, the Heads Up Act, has not passed yet.
Actually, it's the exact same thing. It's not different at all. The Heads Up Act was the result of our recommendation. After we recommended that people with disabilities be designated as a special medically underserved population, we found out that Congressman Seth Moulton was drafting the bill and submitting it to Congress. And that bill is a direct result of our recommendation. And to the congressman's credit, his office did draft that bill, and I believe it's got other co-sponsors. It was readmitted each time there was a new Congress. And actually that bill was actually a result of this recommendation, actually. So it's pretty much the same.
Thank you.
Shall I pose the next question, Clarissa?
Sure.
Okay, so I think this question is related to the health disparities population designation. The person who asked the question asks, is some of the research you've mentioned, particularly through NIH, at risk in the current political climate? And I guess related to that, what can we do to make sure that we remain consistent with the HDP designation?
Unfortunately, that's a question that's above my pay grade. That's all I can say on that.
Okay, thank you.
Sorry, I couldn't be more helpful, but that's way above my pay grade.
We have a question in the chat. Is there a place to go that provides information on providers who work with people with disabilities, like dentists?
You mean like is there a place where dental providers can go to for information?
Or a place where a patient can find someone who works with people with disabilities, like a referral list or something along those lines?
Oh, I see. That's a good question. I'm not sure if anybody took the time to make a list of providers in the country that treat patients with IDD or patients with disabilities generally. It might be helpful to contact an organization that is known to provide these services and see if they know anybody close to that patient who could do the same type of thing. So, you know, there's oftentimes a network among medical professionals. You know, people in the field pay attention to the field and you know, befriend other providers who do the same type of thing. And so it might be helpful to contact maybe a university that provides this treatment and see, like, so for example, if you live in Oklahoma, all right, it might be helpful to contact the University of Pennsylvania, University of Pittsburgh that has a good program, or the NYU that has a good program, and see if they know anybody in Oklahoma who provides this type of treatment. Ever since the Commission on Dental Accreditation revised its standards and says that, you know, all dental schools have to train their students to treat people with IDD and other disabilities, we've seen oral health clinics pop up that across the country that provide this service. I just don't know if there's a list anywhere of those facilities. I remember I saw an article where I think one in Houston had opened recently, and others. But I think that might be the best approach, is to contact, you know, to Google a facility that provides the services, call them up and say, hey, do you know of anybody, you know, in my area that provides the same type of service? That might be the best way to do it.
Yes, I think the American Academy of Developmental Medicine and Dentistry has a list, but one of the challenges is that if there isn't adequate funding for the providers, if someone gets too many patients with disabilities who have complex needs without adequate funding, you put them out of business. So that's an irony until we have people who are adequately supported to provide the care. Training isn't enough, and you can't make a list like that without imperiling the very people who are doing the work as best they can. We had another question related to that. Is there funding under the SMUP designation?
That's going to be up to the members of Congress to figure out.
So,
Okay.
somewhat related question about education, and so the general question is, and my understanding is that the NCD is a policy setting organization, and so the question is, how do you get the training programs, whether they're medical schools or residency programs, to include curricula for future healthcare providers? Is there, you know, how do you go from the policy part to the actual changes in training?
Actually, I'd have to correct you that NCD is actually not a policy development agency. We don't make policy. Our job is to make recommendations to the people that make policy. So we make recommendations to Congress, we make recommendations to the White House, and we make recommendations to other federal agencies that make policy. But we do not make policy. Our job is to just sort of look at what problems exist and make recommendations. But I'm sorry, the second part of your question was, how do you get schools to do this, essentially?
Yes.
We actually can't, right? So what we found in this space is that medical schools in the United States enjoy very much their autonomy. So medical schools, the same way that dental schools have their standards set by the Commission on Dental Accreditation, medical schools have their standards set by something called the Liaison Commission on Medical Education, or Liaison Committee on Medical Education, something like that. But the standards, from my understanding, are broad enough in the sense that both the LCME and medical schools both appreciate the notion of medical schools having as much autonomy as possible on what they set as their curricula for their students. So there is no national mandate currently. It's pretty much up to each school what they treat their medical students, what they train their medical students in. with respect to treatment. So as I mentioned before, there are a lot of schools that do include this in their curricula. Most do not, but over time, we're seeing more and more schools opt to do this. So right now, it's a matter of sort of just, non-governmental organizations are having conferences about this issue. You're having a conference about this issue to an extent today, and just sort of sharing information between providers and between heads of schools and heads of residency programs on the importance of this and the need of this and how you might go about doing this. And any school that wants to go about doing this, there are a lot of other schools that they could sort of look to for guidance on how to approach this. The same way that residency programs can look to some other residency programs for guidance on how to do this.
Thank you very much, and thank you for the clarification about the policy setting. And my just my interpretation then is, professional organizations and organizations of schools or programs, residency programs, can play a major role in this. And then sort of a related specific question about nursing school curriculum and whether there's inclusion of training recommendations on disabilities at the RN, nurse practitioner NP or DNP levels.
It's NCD's recommendation that nursing schools also train their students in disability, clinical care, and competency. And I think it's the same situation where some schools, nursing schools, provide said training, and others still need to.
Thank you.
The Developmental Disabilities Nurses Association has a certification program for nurses with a pretty rigorous process for becoming a certified developmental disability nurse. And so that might be one avenue. And also, while government can't compel medical schools and health profession schools, there are accreditation organizations that accredit training programs that might be a place to target.
Yeah, and just building off that, I'm actually glad you mentioned that yeah, we can't compel schools or residency programs to do this. And I would just point out that with respect to our recommendation to the American Dental Association, kudos to them that they took that recommendation, right? There was nothing that could compel them, that we could, do to compel them to do it. They took a look at their code, and they realized that this is something that they needed to revise, and they chose to revise it to their credit. Similarly, with the Commission of Dental Accreditation, kudos to them. There's nothing we could do to compel them to do this. We could just recommend that this is something that they should do, and good on them that they themselves decided to make that revision of their own will. And I think it's had a very positive impact since. And for those medical schools or residency programs that choose to do this, they're doing this out of their own volition. And I would say, again, good on them for doing it.
So thank you. And related question, New York has great oral health care access for people with disabilities because New York State requires general dentists to have dental residency training. Few or no other states have this requirement. Is it possible for NCD to advocate for this in every state training dentists?
Well, NCD doesn't, and I know that, people might be using that term, non-selectively, but NCD does not advocate. We do not lobby. We do not advocate. What we do is we take a look at the research, the data. We talk to people in the community, and then we come up with recommendations for our federal partners, and then it's up to the federal partners to either accept or not accept the recommendation. But I guess what the questioner is asking is, would it be our recommendation to the other states that they require this the same way New York has? I mean, yeah, we would love every state to require this, right? We can't force the states to do it, but we think it's good. We think it's a good recommendation to follow for sure.
Thank you.
So there was another avenue. A participant in the conference commented, I was on the ANCC standards board for creating the latest ANCC questions for the current psychiatric mental health certification test, and participated in the board for writing new questions for the current nurse practitioner national certification for psychiatric mental health advanced practice certification. So to the extent that the people at this conference are experts in participating in their professional organizations and participating in setting the standards and the exams, we might be able to take what NCD has done as backup for our arguments to put that good policy advice into practice. I don't know if NCD has any ability to work with those organizations that set standards.
Sorry, could you boil down the question? There was quite a bit that came across there.
Well, can NCD take this great policy work that you've done and put it in the hands of the people who make test questions for certification exams, for example, or like board certification exams or board certification standards?
Right. So our job is to make recommendations to our federal partners. That's our mandate. Now, there's nothing precluding an organization like, some of the NGOs that we've talked to from taking our recommendations as well, right? And some of them have done so. But we're a small outfit, and we have our hands very full with making our recommendations and working with our federal partners. Each state is responsible for their own questions on certification exams and the exams that doctors have to and residents have to take. We don't have the bandwidth to work with each of the respective 50 states on this issue, but we have heard of this idea before, such as if you put a disability clinical care and competency question on a licensing exam, that would encourage the medical schools in that state to teach to that question, right? And then other people say, well, it's the other way around. If the schools would teach and train their students in this space, then those questions will start popping up on the exams, right? And it becomes kind of like, which came first, the chicken or the egg, right? Well, ideally, we would want both to happen. We would want to see these questions pop up on the exams, and we would want to see the schools include this in their curricula. But those are decisions that each state have to make for themselves.
Now, I know that that disability traditionally has been a bipartisan issue. You talked about the Americans with Disabilities Act, which was Bush, and we have in California the Lanterman Act, which established the regional center system, which is our developmental services system, and that was signed by Ronald Reagan. But there's a lot of anxiety about the current political situation and a question about what is the plan for your council to survive this administration and its hostility towards government institutions and norms. Will you archive your work in a non-governmental site in case we have to pick through the ashes to rebuild?
I'm afraid I'm not permitted to discuss any of that, and I don't even know if I would have any answers. Again, all that is way above my pay grade.
Amjad, you do collect data, And I noticed that when you made when the recommendations were made, the core recommendations, that although you can't force states or force medical schools to adopt the recommendations, it sounds like you do track what happens, and that information can be really helpful. Especially, I think although the oral health coverage was not part of the 5 core, just your explanation about what happened with Nevada, or what happened in certain medical schools, or etc. And is that something that you routinely track then over time? Because that would be very useful, especially if there's a way to see that things are leading to positive outcomes, including cost savings.
We don't currently track which medical schools include this in their curricula and which do not. We have a very, very, very small budget at NCD. So there's only so much we have the sort of resources we need to track and take a look at. That would make for an interesting report, in my personal opinion. But anything that we do, any data that we do collect, anything that any reports that we have put out, and I guess this was the last slide we never got to in my presentation, is on our website at ncd.gov. And I think that slide also included my email address if anybody needed it as a follow-up to this presentation. Yeah, we do our best with the budget that we have. We've been called the little engine that could, right? We hope that's the case, and we're very honored when people refer to us as such. I think that considering how small we are, we have put out a lot of good, solid reports that I think people should browse through and can browse through at ncd.gov.
Well, thank you so much.
Thank you so much for coming and sharing the wonderful breadth of work that NCD has done. I have been to your site and downloaded your reports many times and used them as references and work that I'm doing, or to help bolster policy work that I'm doing. So you are having a tremendous impact, and you can tell from your legislative successes that you are making a difference, and we deeply, deeply appreciate this work and want to support you to continue it. Thank you so much for being here today.
Well, thank you for having me, and on behalf of MCD, I just want to say thank you again for this opportunity to share some updates from the work we've done. Appreciate it.
Thank you so much.